Good afternoon. My name is Mason Hedberg from University of Chicago and North Shore University Health System. I'd like to thank SAGES and Drs. Farrell and Bittner for the opportunity to present our institutional outcomes of individuals with preoperatively asymptomatic inguinal hernias after a laparoscopic, totally extraperitoneal repair. And we have no relevant conflicts of interest or disclosures related to this work. Repair of asymptomatic inguinal hernias is a controversial topic. Many individuals can comfortably and safely live their entire lives with a hernia that's not causing any problems, and over the years, many arguments have been made for and against repair. Arguments against repair include avoiding unnecessary healthcare expenditures and risks associated with minor surgery. Additionally, adverse events associated with not operating are rare. Incarceration occurs about 0.5% per year, and strangulation 0.5% over 4 years. Reasons to operate are that about 2/3 of patients will eventually develop symptoms and have a surgery at a later age, and that watchful waiting carries increased risk of having an emergent repair. Also worth considering is that laparoscopy offers less postoperative pain and a faster recovery, reducing the impact of surgery upon a preoperatively asymptomatic individual. So for this study, we compared quality of life measures, intraoperative findings, and surgical outcomes between patients with pain-free versus painful inguinal hernias after totally extraperitoneal or TEP laparoscopic repair. Our null hypothesis was that was that there would be no difference between the groups, and the alternate that asymptomatic patients would experience less postoperative pain. We queried an institutional database of operations performed between 2009 and 2015 by 4 surgeons and found 638 laparoscopic TEP repairs, 387 of which had the necessary data available after chart review. The asymptomatic cohort was assembled by 79 patients who reported a pain score of 0 at their pre-op clinic appointment, and all other scores assembled the symptomatic group. Assessment measures were the short form 36 for general quality of life, surgical outcomes measurement system, or SOMS, which is a relatively new assessment similar to SF36 but specific for surgical patients, and Carolina's comfort scale, which is a hernia-specific measure. SOMS and SF36 were administered preoperatively and at 3 weeks, 6 months, and 1 year postoperatively, and Carolina's comfort scale was administered only postoperatively as intended by design. This is a comparison of the patient demographics. 20.4% of individuals reported a pain score of 0 at their preoperative appointment. The only significant difference between cohorts was increased age in the asymptomatic group. We suspect this might be due to pain-free individuals taking longer to seek surgical consultation than symptomatic patients. The analysis of quality of life measures was adjusted to account for the age difference. From intraoperative data, we found that the procedure time was identical and laterality was not significantly different. The asymptomatic group had a lower proportion of indirect hernias, which may suggest that indirect hernias are more likely to be symptomatic. The increased size of the hernia defects in this group may reflect the older age of the cohort, or that larger defects are less likely to be symptomatic. Postoperatively, there was no difference in length of stay or complications. The asymptomatic group stopped pain medications 1 day earlier and returned to baseline activities of daily living 2 days earlier. There was 1 recurrence in the asymptomatic group and 2 in the symptomatic group. So again, the asymptomatic cohort was assembled with individuals reporting a pain score of 0 at their pre-op appointment. The SOMS measure also includes a pain scale, and the chart on the left shows that the clinic's pain score was very different from the SOMS pain score. About 50% of individuals that reported no pain in clinic reported some pain on SOMS, and the symptomatic group reported less pain on SOMS than they did in clinic. However, the difference between the SOMS pain scales remained significantly different between the 2 groups. On the right, we show the SOMS pain score over time with significant differences at pre-op and at 3 weeks. We used longitudinal mixed effects models to compare the quality of life measures, and the significantly different ones were pain impact and pain quality by SOMS. Pain impact is on the left, scored from 6 to 30, and pain quality on the right from 4 to 21. lower scores are better for both scales. It's interesting to see that the impact of pain in the asymptomatic group actually went up or got a little worse at 3 weeks, whereas the symptomatic group improved. These charts show the proportion of response type by patients to the various Carolinas Comfort Scale questions, from no symptoms at all to disabling on the x-axis. Asymptomatic patients are on the left and symptomatic on the right, and the different colors are the different time points. There were significantly more no symptoms responses by the asymptomatic cohort at all 3 time points. So in summary, 20% of patients that had laparoscopic totally extraperitoneal repair of an inguinal hernia reported no pain at their pre-op appointment. However, about half of these reported some pain on SOMS. This cohort was also older, had larger hernia defects, fewer indirect hernias, stopped taking pain medications, and returned to activities of daily living earlier, and reported decreased pain impact and pain quality by SOMS. Prior studies have demonstrated that preoperative pain is a predictor of postoperative pain, and in a similar vein, our results suggest that lack of pain preoperatively may predict less pain postoperatively. We can conclude that elective, totally extraperitoneal repair is safe for patients with pain-free hernias. Thank you very much.
Any questions from the audience? I'll ask one. How do you counsel patients with asymptomatic hernias regarding repair versus watchful waiting?
Speaking for the surgeons in the group, I think they just have a discussion, discuss the risks of both approaches, and just let the decision be between mostly up to the patient, I believe, just whether they prefer to have repair or not.
All right. Thank you very much.
Thank you.